Andrea. I will be your student nurse for the day. The doctor's ordered some enteral feeding or feeding through your nasogastric tube. Do you have any, may I have your name and date of birth, please? Okay, do you have any concerns or questions at the moment? And are you having any nausea? Do you feel like you want to vomit? And do you have any stomach cramping? Nope. Everything feels good. Okay, have you had a feeding before? And do you know what to expect? Explain to them the procedure. I'm going to elevate the head of the bed at least 30 degrees during the procedure, and then at least for 1 hour afterwards to prevent for any aspiration. First and foremost, I'm going to listen to your gut sounds, providing for privacy as well. Going to listen to your gut sounds to make sure that your bowel sounds are, your bowel is moving. Make sure that there's no absence of bowel sounds, and if it's hyper or hypoactive, and I will document that later in my findings. And I will also check for placement with 2 methods. First method being I'm going to unclamp, aspirate some fluid, reclamp. Hold it. I'm going to check the pH on a reagent strip, which should be about 2 to 4. Yep, that's good. Then I will rinse out my syringe. I will put in about 15 milliliters of air. And at the same time, I will listen to the epigastric area, and I will insert 15 milliliters unclamping, 15 milliliters of air, and listen for the whooshing sound. As long as that's accurate, and also too, the patient doesn't develop any coughing. You can also auscultate the lungs to make sure that there aren't any advantageous respiratory sounds and that it doesn't elicit a cough. Same with placement. So once I assess placement, I'm then going to check my tube for aspirate content. I'm going to aspirate as much gastric fluid as will allow without residual pressure. So once I hit pressure, I will stop aspirating. I will measure the amount that I get out. If it is 100 milliliters, I will withhold the feeding and retry in an hour. If it's 200 milliliters or half of the previous feeding, I will withhold feeding completely and ask the provider. Whatever contents I took out, I will then replace. I will then replace and then recap and repeg. I will then take my water, drop 30 milliliters of water. Oh, I apologize. I have 30 milliliters of water available and my solution. Before I give my solution, I will check the expiration date. I'll check the material, the contents, the bottle itself, make sure that it's clean and it hasn't been broken. And I will also check that it's at room temperature. You want the material at room temperature. So I'll have available next to the stand the food and the water. I'm going to keep my tube clamped. I'm going to instill the syringe on my clamped tubing. I will then take my water, tube still clamped. I will pour in 30 milliliters of water. I will slowly release the clamp, keeping the tube at head height or higher, depending on the speed and depending on my patient's response. If he starts to feel nauseous, I can lower the tube and make it go slower. If he's tolerating things well, I can raise the tube and make it go faster. Once the 30 milliliters is in, before air starts to get into the tube, I will pinch it closed. And then I will take my food depending on the quantity I need to do. I can start with about 30 milliliters just to see how gravity is going to go and how it's going to flux, how it's going to flow, and how the patient's going to tolerate the feeding. And then if it seems to flow kind of slow, some of them are a little thick, you can drop a little bit of water just to get it moving. And if he's having trouble with any nausea during this procedure, I can clamp it off, give him a minute rest, or I can slow the trickle feeding down. If he continues to have nausea, we can stop the procedure and have him reevaluated, listen to his gut sounds. And if he does go to vomit, pull his head towards the side so he doesn't aspirate, and have suction available. Once my feeding is complete, once the volume is complete, then I will flush another 30 milliliters of water, let that go in, and then when that goes in, then I will clamp everything off. And I'm going to document how much I fed and how well the patient tolerated it. I do want to keep both tubes above the patient's stomach area. Ideally, you can keep them above the patient's head. Then I will ask the patient how they tolerate it, keep them in the 30-degree angle or higher for at least 1 hour after feeding, but lower the main bed to its lowest position. And cap off, clamp, make sure that everything is intact, the patient's tube is secured. And that's it.